Good evening, everyone. I am Parthasarathy again in my channel Pain Free Partha, and a lot of my slides, more than 400 slides, are available in www.painfreepartha.com. Free download. Today, the topic is about the basic physiology of kidney. Fundamental, very basic. Now, there are two normal separate kidneys, right and left. Each has got own capsule. They are located retroperitoneally. The level is T12 to L3. They are approximately around 12 centimeters and weigh 150 grams each. So two kidneys, retroperitoneal, T12 to L3, 12 centimeters and 150 grams. The right kidney, you can see the right kidney is slightly lower than the left kidney because the liver is slightly pushed. The upper part of the kidney, you can see here, the upper pole of the kidney is slightly protected from injuries by the ribs. What are the parts of the kidney? Now this is the renal cortex, and above this is the capsule. The capsule, the cortex, the medulla. Now in between, what are the things? The renal medulla, and the inner region of the renal medulla is made of renal pyramids. You can see these pyramids, which contain the collecting ducts and the loop of Henle. Renal pyramids are the cone-shaped structures that contains collecting ducts. Now here the cortex, the medulla, pyramids, and the renal columns in between this. They consist of tissues to provide structure and support. Yes, again the renal pelvis. Now you can see here the renal cortex, the renal medulla, the renal pyramids, the renal columns. The renal pelvis is the funnel-shaped structure which collects the urine. Okay, renal medulla. Should not confuse medulla with pelvis. The nephron is the fundamental functional unit of the kidney. This is a nephron, is a fundamental. Glomerulus filters waste, the toxicity which absorbs, the loop of Henle which concentrates and dilutes, the DCT which absorbs. Now, what are the functions of the kidney? To regulate, to produce, to excrete. What does it regulate? Extracellular fluid volume, extracellular electrolytes, the body's acid base, water volume, BP, so much things it regulates. Now, for example, it dilutes urine and changes the fluid volume. It pours out sodium chloride and changes the electrolyte balance. It pours or secretes or picks hydrogen ion to make changes. It produces renin to make alteration in blood pressure. So these are all the things which functions of the kidneys where it is regulation. To produce the active form of vitamin D and erythropoietin, renin and some part glucose. And to excrete lot of waste products and also some drugs, metabolites of drugs. Now there is a small difference. This loop of Henle is slightly elongated in the juxtamedullary nephron, where the normal nephron is like this. Now you can see the proximal convoluted tubule, the descending limb of loop of Henle, the ascending limb of loop of Henle, the distal convoluted tubule, and the collecting duct. You can see here the cortex. The cortex contains mostly the convoluted tubules, and the loop of Henle comes to the medulla. You can see here the medulla. What are the functions of the proximal collecting tubule? It absorbs sodium, water. The water is big here. Bicarbonate, chloride, and glucose. What is the function of the loop of Henle? It dilutes and concentrates urine. The countercurrent mechanism operates. Now you see this is the descending limb of the loop of Henle. Water is resolved. Urine is concentrated. If the body is dehydrated, more water is resolved, resulting in a concentrated urine. Now this is about if the body is not dehydrated, full, less water is dissolved and more of a diluted urine. Now we can see in this ascending limb, sodium and chloride are actively transported out. Sodium chloride actively transported out, and it results in a concentrated urine. So it depends upon what it needs. So this is about water, this is about sodium and chloride. Now we know what are the functions of the PCT. Proximal convoluted tubule is mainly about absorption of water, and the other thing is about chloride, glucose, sodium, etc. The loop of Henle is about concentration and dilution. The distal convoluted tubules is also water and sodium absorption, calcium, but the most important thing is about acid-base regulation. It secretes hydrogen ions. It resorbs bicarbonate. That is how it takes part in acid-base. Hormonal regulation is also in the DCT. For example, PTH and aldosterone. There is one thing called juxtaglomerular apparatus. Juxta means near. Near the glomerulus, there is something special. This is what is called juxtaglomerular apparatus. Now we can see the glomerulus. This is the Bowman's capsule. The glomerulus, this is the afferent arteriole. This is the efferent arteriole. There are some changes in the afferent arteriole. These cells have changed. These are called juxtaglomerular cells. Now, by the side of it, the ascending limb of the loop of Henle will come. And this thick ascending limb will have some changes in the cell. They are called macula densa. So, the loop of Henle changes macula densa. Glomerular changes juxtaglomerular cells. There are some mesangial cells. All these three are called these mesangial cells. This is what is called the juxtaglomerular apparatus. In the macula densa, it produces renin. The juxtaglomerular apparatus is needed for sodium resorption or taking in. Around 1 to 1.2 liters is the renal blood flow. Renal blood flow, 20% of the cardiac output. Now you see, the cortex received 90% of the blood flow, but it is least metabolically active, while 10% goes to the more metabolically active medulla. Only 10% goes. So it is the Bowman's capsule and the afferent arteriole and efferent arteriole. This is the most important difference between any other tissue and this. Now you can see here, the arteriole, normally what happens, after the capillaries, vein starts. But here, arteriole, capillaries, again an arteriole, and again goes into another set of capillaries, and then goes to the renal vein. This is what is called the glomerulus capillaries. That is needed for filtration of urine. Now, how it is filtered? There are basically two things. How much is pushed out from the glomerulus? That is what is called hydrostatic pressure of the glomerulus. Okay. How much is taken in? It depends upon the oncotic pressure of the glomerulus. Here the reverse. Oncotic pressure of the Bowman's capsule and osmotic pressure of this Bowman's capsule. Here the osmotic pressure is high, it will not come. Here the oncotic pressure is high, it will suck in. Understand? So if you have proteinuria and if the oncotic pressure is high, more is sucked in. That is the problem. So that difference is hydrostatic pressure versus hydrostatic pressure. Glomerular oncotic pressure versus Bowman's oncotic pressure. Segmental arteries or end arteries mostly. The kidney sympathetic nerve supply comes from T8 to L1 spinal cord, which forms the renal plexus, which causes vasoconstriction, stimulates renin, regulates filtration, regulates absorption. You can see the renal artery, the segmental artery, the interlobar artery, and the arcuate artery. This is the typical picture of the arterial supply of the kidney. So segmental are usually end arteries. They are supplied by the sympathetics from T8 to L1. Now you see, if the sympathetic is blocked, does it cause vasodilatation of the kidneys? Because sympathetic is in charge of vasoconstriction. So spinal may cause renal vasodilatation. But all that doesn't happen because in routine spinal anesthesia, cardiac output is maintained. Whatever it is, nothing happens. Only if the level is very high and there's a hemodynamic imbalance, the renal blood flow can come down to 200 to 300 ml. This is very important in patients where there is atherosclerosis, old age, diabetes, hypertension. All these things are there, this matters. And otherwise, it doesn't matter. The kidneys have mechanisms designed to preserve GFR within a certain range. That is myogenic and tubuloglobin. Now the GFR is maintained from BP 80 to 180. Why? Myogenic and tubuloglobin. Now what is myogenic and what is tubuloglobin? Now if you stretch the afferent arteriole by an increase in BP, the smooth muscles and the accelerols causes the afferent arteriole to constrict. That is why the BP response and GFR is adjusted. The afferent arteriole dilates in response to decreased BP. So the GFR is maintained. The tubuloglomerular feedback is different. The macula densa senses the sodium delivery, triggering vasoconstriction. Macula densa senses if more NaCl is coming now, it produces there to decrease the NaCl. That is how it acts. Same afferent arteriole diameter is changed, but here it is myogenic. There it is related to sodium chloride and then renal release. That is why it is instantaneous. This takes some time, few minutes. Now we already told 1 to 1. See here, 1 liter blood flow. GFR is 125 ml per minute. Glomerular filtration rate. That's around 180 liters per day. But 99% are reabsorbed. So 1 liter urine filtered, only 1 ml urine is formed. Actual urine filtrate is 180 liters, around per day, approximately 1800 or 1500 ml urine is. More than 69,000 Dalton's molecular weight cannot be filtered. That is about albumin. But 68,000 free hemoglobin go. So mild damage to the glomerulus, albumin leaks. If the albumin is more in the Bowman's capsule, what happens? The oncotic pressure rises. It sucks in fluids. It sucks in so many things. So that is the problem. Glomerulus leaks, albumin comes down. The albumin will further worsen the normal physiological glomerular filtration. Now, low serum albumin at 2.4, that is what the problem is. Fracture femur, total knee arthroplasty. A lot of patients, anesthesia, drug problems are there. Serum albumin decrease is associated with more surgical site infections. So now we know the renal blood flow is around 1 to 1.2 liters. Now if you crush it, how much time will it take? Usually 20 to 30 minutes of ischemia is accepted. Renal ischemia produces acute tubular injury, acute tubular necrosis. It doesn't cause much of glomerulus problem. Tubules get affected because possibly a high metabolic demand, a vulnerability, a tubuloglomerular feedback, and further ischemia. All these things make acute tubular necrosis more common than acute glomerulonecrosis. But it cannot be completely flattened to tell like that. Yes, it also depends upon what is the patient like. If the patient is already at diabetic, hypertensive, old age, all these things have to be carefully settled. Now, a major colonic surgery with light anesthesia. Hypotension, this may cause renal compromise, otherwise it may be normal. Anesthesia and surgical stress affect renal function, body flight regulation, both directly and indirectly. Now you see indirectly, spinal if you give, GA if you give, BP will fall, cardiac output will fall, that will cause your renal blood flow to decrease. This is a direct effect. Indirect effect. What is the direct effect? Agent can cause glomerular filtration rate to be problematic. Reduction may be directly due to inhalation agents. Preoperative hydration is very important. Now, what all I'm saying is 200, it becomes 200 to 300 ml. If there is a level of T1, now if there is a preoperative dehydration, think of this. So these things can be maintained by a good preoperative hydration, a good preoperative hydration, a good preoperative hydration. I'm repeating it again and again. Opioids, barbiturates, benzodiazepines also contributes to decrease the GFR and urine output. Regional anesthesia has less impact on renal function. It is because of the systemic hemodynamic changes. Usually, all these changes are transient, clinically insignificant. It's a fast. Mechanical ventilation can decrease urine volume, sodium excretion, probably an increased intrathoracic pressure. There is an auto-regulation of renal blood flow also, and anesthesia can interfere with this self-regulation. ADH helps the kidneys to retain water. Anesthesia may alter ADH. We have seen postoperatively immediately syndrome of inappropriate ADH secretion. Tubular transport of sodium and organic acids can also be affected. These are all the possible direct effects. What all I told as indirect effect is the cardiac output decrease. Regional anesthesia can cause cardiac output to decrease. General anesthesia can cause propofol, pepinto, can cause vasodilatation, cardiac output to decrease. Then indirect. Direct effect is about autoregulation is gone, ADH is gone, tubular transport is gone, and methoxyfluorine also directly affects. Sympathetic tone regulates the range of blood flow autoregulation. So maintain stable renal blood flow over a period of systemic sympathetic conditions. So we have to be careful about sympathetics, because the worst thing is if you give spinal with the GA. At least epidural with the GA is okay. If you give spinal with the GA, the output is, the renal blood flow is decreased because the sympathetics are grossly blunted, so it cannot compensate, it cannot regulate, it cannot auto-regulate for a propofol-induced hypotension. Not much change, auto-regulation maintained, but T1 may be associated with this. Already I have told. Additional factors, renin-angiotensin. Direct anesthetics. Only proven is already I have told, methoxyfluorine. More dependent on ROS to compensate for the loss. For example, the patient is in beta blocker, the patient is in Dexamet, the patient is at central, it needs ROS. So we need to have renin-angiotensin aldosterone mechanism to be paka. So what is the renal blood flow? Yes, renal blood flow is 1 to 1.2 liters to 20% of the cardiac output. What is the GFR? 125 ml per minute. So even though it is 125 ml per minute, the filtrate is around 180 liters per day, out of which only 1,500, 1,600, 2,000 ml is pushed out as urine. What are the parts of the nephron? It comes as an afferent tubule and efferent arteriole. Afferent arteriole, that's the only place. Arteriole becomes capillaries, becomes veins everywhere. Arteriole becomes capillaries, becomes again arteriole, is kidney. What is the various function? PCT is sodium absorption, glucose absorption, water absorption mainly. Convoluted tubule is about this thing. The ascending and descending, concentrating and dilution. Again, if you go to the DCT, the most important is also sodium and water absorption. But another thing is humoral with aldosterone, who is acid-base balance about the DCT. Then the collecting that forms and goes out of the urine. Cardiac output, always see, and not blood pressure, because maybe 65 because of your increased SVR. ADH, yes, we know. Fluids, pre-op hydration. Regional anesthesia at T1, beware, especially in other comorbid conditions. Agent can cause, opioid can cause, benzodiazepine can cause slight suppression of renal pressure. Yes, Ultimately, urine output is the best sign of kidney function. Thank you all. Visit me at Pain Free Partha in my website and also